Going back to our surgical epilepsy and SEEG series. Tonight we have Dr. Lisa Knopf, who will be speaking about the interpretation of intracranial EEG patterns in stereo EEG. Dr. Knopf is assistant professor at the University of Connecticut School of Medicine and is also assistant director of the epilepsy surgery program at Hartford Hospital. She completed 2 fellowships in epilepsy surgery, epilepsy, at Cleveland Clinic and Beth Israel Deaconess Medical Center. Her academic passions are functional neuroanatomy and updating surgical epilepsy curricula to reflect the rapidly. The way that this will work tonight is that Dr. Knopf will first give her talk, and at the end of her talk, she will be open to taking questions. So please, if you have any questions that you'd like to ask, go ahead and put them in the chat box, and we'll hope to address as many of those as possible. We'd love for this to be an interactive session. To ask whatever questions you have. And with that, I'd like to offer a warm welcome to Dr. Knopf.
Thank you so much, Dr. Bullinger. I'm delighted to be here tonight. So my talk is going to be on the interpretation of intracranial stereo EEG. And it's going to be a little bit of a talk. First, I want to focus on discussing the history of intracranial EEG and the evolving definition of the epileptogenic zone. We'll talk about how we interpret these without knowing how we've come to perform intracranial EEG over the past century and how things have changed. Then in the second part of the talk, we're going to learn how to recognize common interictal findings in specifically stereo EEG. We're going to talk about recognizing seizure onset patterns and seizure propagation patterns. And we're going to look at, when possible, their relationship to surgical outcomes. Finally, we will identify seizure onset patterns that may reflect specific. So, intracranial EEG has been taking place as far back as the 1880s, starting from the 1880s through the 1900s in the operating room using electrocorticography or ECOG. Then in the 1960s, with the arrival of the French school, Banco and Talleyrand, the method of stereo EEG or stereotactic EEG was developed. In the 1990s, Hans Luters and the North American school began to use subdural grid electrodes to explore more extensive regions of superficial cortex. And then starting in the 2000s, all the way until the present, there was an explosion in technology and an understanding of epilepsy, not as a disease of a seizure focus, but as a disease of networks that's really been informing how we do our intracranial EEG explorations. Over time, there's been a trend toward including more and more brain regions in order to capture the epileptogenic zone. So again, from the 1880s to the 1950s, epilepsy was thought of in terms of a seizure focus. Who underwent intracranial EEG typically either had tumors or pollutants. They were taken to the operating room where they had corticography. Patients were very brief, lasting just an hour or two. Seizures were almost never captured. Was typically exposed and regions of spiking were exposed. So typically the lesions were in the sensory motor cortex and functional mapping could also be done. And epilepsy was really thought as a disease of a focus where there was a lesion and then there were spikes around it. And you could make a patient seizure free by removing the lesion and removing as much of the spiking as possible. In the 1960s, things changed a bit. So Banco and Talleyrand in Marseille, France, they believed that since epilepsy surgery aimed to cure seizures and not so much to cure spikes, or it was critical to understand how the ictal patterns cause clinical symptoms. Also keep in mind that back then, there was no CT or MRI, was X-ray and pneumocephalogram. So usually there were no lesions to be explored. So given that they wanted to explore how the ictal patterns caused clinical symptoms, they developed a method called stereotactic EEG, where depth electrodes were stereotactically placed using a frame to explore various structural and functional neuroanatomical regions. They found that often, even when there was a lesion, that often the seizure onset was in a region distant from that region. So they developed the term of the epileptogenic zone, which is the site of the primary organization of ictal related to the presence of a lesion itself. Because they wanted to analyze how seizures evolved spatiotemporally from beginning to end, they developed the concept of anatomical electrical clinical correlation, which is a key concept that's still used. And this is defined as analyzing electrical seizure activity as it evolves in time in different structures, both in the seizure onset and in early propagation, with direct comparison with the clinical semiology as it unfolds to form a spatio-temporal view of seizure organization. So this was kind of amazing. This was they sort of developed the concept of epilepsy as a disease of networks before networks were ever understood from from a neuroscientific perspective. So in the 1990s, subdural grids came with Luters and the North American School, and they became the predominant form, at least in America, of intracranial EEG exploration. So these studies placing grids over large amounts of superficial cortex, which allowed for pretty exquisite mapping of interictal spiking, as well as seizure on. It was superficial, and as well as the location of the seizure spread. Because there were so many electrodes located over the superficial cortex, functional mapping could also be done in exquisite detail. So based on this, Luters in the North American School defined some different terms. So the ictal onset zone was defined on scalp EEG and stereo EEG, as well as non-invasive studies like SPECT scans. The irritative zone, region of maximum interictal spiking. The lesional zone was obviously the region where there was a lesion. The symptomatogenic zone was the region that was generative of clinical semiology, not necessarily in the same region as any of the other zones discussed. And the epileptogenic zone was something separate from all of these things. It was defined as that was indispensable for the generation of seizures, of which total resection or disconnection is necessary and sufficient for seizure freedom. So this is an important concept. The epileptogenic zone is a theoretical concept. You don't know what it is until the region of brain has been resected and then the patient remains seizure free. It usually includes the seizure onset zone, the region where the seizures start, but it doesn't always include the entire thing. You might have to exclude some of the seizure onset zone if it is located in the eloquent cortex, and it may need to include some of the irritative zone. It may need to include some of the lesion. It may not include the lesion at all. So this was a new definition of the epileptogenic. And in the 2000s, with again an explosion of new technology, epilepsy came to be seen even more not as a disease of lesions, but as a disease of networks. So what's a network? This was first defined by Dennis Spencer at Yale in 2002 as a functionally and anatomically connected, bilaterally represented set of cortical and subcortical brain structures and regions in which activity in any one part affects activity in all the others. So think of a network as a set of nodes in which activity in one node can affect something in another node upstream or downstream from it. Epilepsy as a network helped to explain, or helped in the development of devices such as vagus nerve stimulation, responsive nerve stimulation, and deep brain stimulation. technologies which can palliate seizures through stimulation of upstream or downstream nodes in the network, so the vagus nerve, the thalamus, cortical regions that are distant from the ictal onset zone, without actually being directly in the ictal onset zone. Different technologies such as MEG and fMRI EEG, and SPECT scan, high density EEG, cortical evoked potentials, and connectivity analyses and graph theory were all different. There are clinical and research techniques that were used to help understand this concept of epilepsy as a network. So given all of that, you know, there are still at different epilepsy centers, I kind of learned this during my fellowships, there are different ways that teams tend to view epilepsy. Some are more in the North American school and using a lot of grids for surgical explorations. Other centers are using more of the European school and doing largely stereo EEG. In my experience, it's good to have familiarity with both schools of thought and both types of surgical explorations, so you can really maximize your options for what you can do depending on the type of epilepsy and hypothesis that you have for your patient. So just some definitions to get us started. So the epileptogenic zone, as we said, is the site of the primary organization of ictal discharges, according to Bancode and Talarak, or the area of cortex indispensable for generation of seizures, of which total resection or disconnection is necessary and sufficient for seizure freedom, according to Luters. The seizure onset zone, which I will call the SOZ, is the area of cortex from which seizures are actually generated. The irritative zone is the region of maximal interictal spikes. And then the lesional zone is the region of structural abnormality. So given what we talked about, just a brief overview of how you would choose an invasive method, which could kind of be a whole separate talk, but just an overview. So some scenarios. So number one would be a patient with a lesion on their MRI where the potentially epileptogenic lesion is superficially located near or in the proximity of eloquent cortex. Now, this would be a good candidate for a subdural grid exploration because the grid is going to be located on superficial cortex, and because grids, given the close spacing of the electrodes, allow for really good functional mapping of cortex. Non-lesional cases where there's no lesion on MRI, but where your hypothetical epileptogenic zone is in the proximity of eloquent cortex, this is also subdural grids may be your method of choice, although not always. Your second option in these cases would be stereo EEG, especially if you suspect in the non-lesional case, like you might have a bottom of sulcus lesion, meaning a very small, sub-MRI focal cortical dysplasia that is not going to be adequately captured by subdural grids. So that's scenario one. Scenario two would be a lesional MRI where your potentially epileptogenic lesion is located in deep cortical or subcortical areas. So like the insula, mesial frontal lobes, basal temporal lobes. Stereo EEG is ideal for this because with electrodes being stereotactically placed, no craniotomy is required, and the electrodes can traverse from lateral to mesial cortex, allowing exploration of the explore with subdural grids. Same thing with in a non-lesional MRI, same thing if you suspect deep or cortical or subcortical involvement, or if you just aren't too worried about eloquent areas and you don't feel like you need to do a lot of functional mapping, stereo EEG would probably be your first choice. So scenario three, if you need to do bilateral explorations or somebody failed their first surgery and you need to consider a second surgery, then stereo EEG again is optimal, just given the morbidity of the procedure and the better simplicity of bilateral explorations. If somebody has failed a subdural grids exploration, often they will be going for an SEEG as their second line procedure. So that was scenario four. Scenario five is when the anatomical electrical clinical hypothesis suggests the involvement of a more extensive multilobar epileptic network. So we're going to get into what that means exactly in coming slides. But in these cases where you're suspecting a network epilepsy, then stereo EEG is pretty exploration technique of choice. Finally, in suspected frontal lobe epilepsy in a non-lesional MRI scenario, these are very difficult cases. You know, those of us who do epilepsy surgery consider these some of the more difficult ones. Stereo EEG is typically best for this in order to explore different frontal parietal, frontal occipital networks. Okay, so what is a network epilepsy? This is an epilepsy in which there is suspected involvement of more than one lobe, possibly with multiple nodes upstream or downstream from a lesion, if there is a lesion. In a network epilepsy, there is suspected seizure spread through different ways, through cortical white matter tracts, through structurally connected regions, through functionally connected regions, or through cortical and subcortical pathways, so corticothalamic, cortical basal ganglia pathways. So just some examples of network epilepsy, because this is just it's a tough concept. One common type of network epilepsy would be a patient with a non-lesional suspected temporal lobe epilepsy. So their EEG and their semiology are suggestive of temporal lobe epilepsy, but they have absolutely no lesion on their MRI or their PET scan. In this case, you're going to want to explore their entire limbic network. And stereo EEG is the ideal way to do this because you really need to do a pretty extensive exploration. This picture is depicting the Talairac grid, which is the way at our center and many other centers that these explorations, a schematic of a brain in Talairac space where each square represents parcellated regions of structural anatomy, and each dot represents an orthogonally placed depth electrode. So in going back to the non-lesional temporal lobe epilepsy scenario where you're trying to look at the limbic network, you would need electrodes pretty much in the entire temporal lobe. You would also want to explore the orbital frontal cortex, which is very closely linked to the temporal lobe through the uncinate fasciculus. That's what this picture of white matter tracts at the bottom of the screen is depicting the uncinate fasciculus. And you also will want to explore the insula in those cases, as the insula and temporal lobe also have many, many white matter connections. So that's one type of network epilepsy. Another scenario would be your temporal perisylvian or temporal plus scenario, where you think it may be a temporal lobe epilepsy, but something about the EEG pattern or the semiology suggests a more widespread involvement, maybe of the parietal lobe, of the insula, of the perisylvian region. In this case, you're going to want to explore so temporal, insular, and anterior perisylvian regions, posterior temporal or posterior insula, depending on the semiology, the basal temporal lobe, the parietal lobe, and the posterior cingulate. Again, stereo EEG is ideal for this. So just one more example of a network epilepsy is epilepsies where you suspect the epileptogenic zone is in the frontal parietal region. So frontal parietal epilepsies can be tricky because there is extensive white matter connectivity between the frontal and parietal lobes through the superior longitudinal fasciculus, a very large white matter tract which connects frontal and parietal regions. Functionally due to connectivity of heteromodal association areas. So there's really rapid anterior posterior and posterior anterior propagation. There can also be pretty rapid contralateral propagation. So in cases like this, you're going to want to explore multiple regions of the frontal and parietal lobes, and usually you're going to also want some electrodes in the other hemisphere to make sure that your epilepsy isn't being falsely lateralized. As we all know from scalp EEG, sometimes parietal lobe epilepsy can just be very poorly lateralizing. It kind of looks just like a parasagittal or central seizure onset, and it can be very difficult to lateralize. So this is why we do these explorations. Oh, and here's our picture of the superior longitudinal fasciculus. Okay, so it's challenging. So we're going to kind of get into part 2 of the talk now, and how do we interpret intracranial EEG once we've made our plan and implanted the patient. So it's challenging to do this, first of all, because there are multiple schools of thought, as we just discussed, about what the epileptogenic zone means, and how to interpret seizure onset. Interpreting seizure onset in subdural grids can be misleading, because sometimes a subdural grid will capture seizure spread as opposed to seizure onset. Visual analysis of EEG is often rudimentary. It's pretty clear that the human eye can only see so much, and quantitative methods of EEG analysis will help make this a little bit more objective in the future. Also, in my experience, there is substantial variation between epilepsy centers in terms of the implantation strategies, in terms of clinical decision-making, and then in the surgical outcomes. So clinical experience coupled with local clinical culture at centers often determines how the EEG is interpreted. There can definitely be some groupthink that happens. All right, so let's get into the nuts and bolts of intracranial abnormalities in stereo EEG. So most of the coming talk is focusing on findings in stereo EEG, with some exceptions, for which I'll point out. So first of all, you need to know your physiologic patterns, your normal physiologic patterns in intracranial EEG. So this is fairly straightforward. So basically, the posterior dominant rhythm, your sleep patterns like spindles, your mu rhythm and normal variance, everything that you can see on scalp can also be seen on intracranial EEG. This picture on the right, I just thought was neat. It was from one of my cases during fellowship, where a patient had a subdural grid, let's see, a subdural grid implanted right over their motor cortex. The label didn't show up on this slide, but it's the grid on the very top of the brain picture. And then they had a lesion right in the motor cortex. So there was this sort of rhythmic alpha beta activity that seen right over the motor cortex. There's an EMG at the bottom of the page of the EEG. And when the patient moved her right hand, this rhythmic alpha beta activity went away. So this was basically what the mu rhythm looks like on intracranial EEG. So one more thing, in orbitofrontal cortex, it is typically physiologic to see delta slowing in that region. It's not necessarily indicative of a lesion or underlying pathology. Okay, so basic approach to analyzing interictal epileptiform discharges. So one, you want to recognize physiologic versus pathological patterns. Two, you want to note the discharge morphology, its relative abundance, the latency of a single discharge, the spatial distribution, meaning anatomical distribution of the discharge, and the relation of one population of spikes to other populations of spikes. It can be very useful to look at interictals and compare them to what you saw on scalp EEG in order to better understand what the scalp EEG translates to intracranially. It's kind of satisfying, and it helps you understand the patient's epilepsy better. So other thing you should do is classify the spikes into separate populations when they're present. This is useful because we're starting to think of the irritative zone as there may be two different types of irritative zones. The primary irritative zone may be similar to the seizure onset zone, located in the same place where the seizure, the seizure organization begins. And the secondary irritative zone may be the region of seizure propagation, so a region that is structurally or functionally connected to the primary irritative zone. Okay, so I'm just going to use an illustrative case of a patient I just finished monitoring recently to show you her interictal activity, and then we'll get to her seizures later in the presentation. So this is patient TB. She's a 37-year-old right-handed woman who's had intractable epilepsy since age 11. She had a completely non-lesional 3T and 7T MRI, also non-lesional. She had a quantitative PET, which is shown on the top right of the screen, which showed hypometabolism in the right orbitofrontal cortex, as well as the dorsolateral right frontal region, kind of at the bottom of the sulcus. We weren't totally confident about this. It's sort of a new technology that we're using at our center. Her MEG showed, at the bottom of the screen, showed dipoles in the right dorsolateral frontal region. Her seizure semiology consisted of, it was pretty bland, typically occurred out of sleep, and then she would have leftward gyration, meaning she would do almost a full 360-degree turn, or left version, and then a generalized tonic-clonic seizure. So really the only lateralizing sign of her semiology was just this version, suggesting onset in the right hemisphere. So we suspected a right hemisphere epilepsy, probably a frontal lobe epilepsy, based on the semiology and the interictal or the findings on her scans, but we weren't certain. So she had stereo EEG implantation done, given what we discussed, how non-lesional frontal lobe epilepsies are really best explored through stereo EEG. And I just wanted to show you what her interictal activity looked like on scalp as opposed to intracranially. So her scalp EEG is on the left and montage, so left on top, right on bottom. She really didn't have any true sharp waves, like legitimate sharp waves I felt on her scalp EEG, but she did have these long runs of 3 to 4 hertz rhythmic, sharply contoured delta activity, which would occur in prolonged runs. On her intracranial EEG, so it's kind of hard to see in this picture, but she had abundant spiking in electrodes located in the right lateral frontal leads. So the RMC electrode was basically located in her right superior frontal sulcus laterally, and then traveling into her the mid-cingulate mesially. The right SMA electrode began more posteriorly, kind of in the premotor cortex, and then traveled to the SMA mesially. And the RAI electrode was located in the frontal operculum laterally and traveled into the anterior insula mesially. So she was having these really nice spikes and sharp waves occurring at 3 or 4 hertz, which were pretty much identical, or pretty much matched right up with that pattern on her scalp EEG. So it's useful, again, to compare scalp and intracranial EEG to understand the epilepsy better. Of her spikes just blown up a little bit to just show the contacts of interest. So I just wanted to show you some other things that you can see when you really analyze the interictal spikes. So you can see, if you look at the RMC into the, or between the middle frontal gyrus into the superior frontal sulcus and then the superior frontal gyrus, you can see that there is a positive polarity of the spikes. And then, so screen on the left, and then the next picture is a referential montage, and you can see that these spikes have positive polarity. So you can see this on intracranial EEG with interictals or ictal patterns if the a sulcus, just due to the directionality of the dipole, whether it's facing toward or away from the electrode contacts. So interictal epileptiform discharge frequency affected by the following. So awake or asleep states, we see that in scalp EEG as well, of course. Medication withdrawal as the meds go down. Early postoperative anesthesia effects. So often in the first day or so after the patient comes out from the implantation, you may not see that much spiking, but then it will increase with time. And finally, so when the hippocampus is implanted, often it's not uncommon at all to see spiking in the hippocampus, which may turn out to be just from irritation of implanting it. That here, the hippocampus is a very irritable structure. And if you find that the spiking goes away over the next couple of days and it's not really involved in the seizures later on, it may simply be a post-implantation effect. Also hemorrhage when it occurs during implantation. It's rare, but it does happen. You can see LPDs at the site of the hemorrhage. So here are just some examples of your classic interictal epileptiform discharges. These were described in a paper comparing subdural grids and depth electrodes of the same spike patterns. And these were patterns that were seen on both grids and depth electrodes. Repetitive spikes. You can see a paroxysmal fast pattern, which is quite difficult to see on scalp EEG, or you could see a slow repetitive spike pattern. So is there any correlation between the discharge morphology and the seizure onset zone? This question was looked at in patients with focal cortical dysplasia. So basically, does the morphology of the spikes tell you anything about whether the seizures are going to start in that same location? That paroxysmal fast activity and runs of repetitive spikes, so that's the first three patterns in the graph on the left, did correlate pretty well with the seizure onset zone, particularly the paroxysmal fast and slow repetitive spikes, whereas isolated spikes did not. Complete removal of areas of more frequent interictal epileptiform activity did not as the morphology in terms of surgical success. So the morphology mattered more than the abundance. And they also found that the irritative zone, the region of maximal spiking, was often larger than the epileptogenic zone. So this paper looked at the correlation between the discharge abundance, latency, and amplitude with the seizure onset zone. So this was another study using subdural grid electrodes. They found that the spike latency, so if you look at the picture on part B, you can see a spike that's being analyzed in referential montage. 1, 2, and 3 are approximately lined up. The channel 3 is a little bit, has a little bit of a latency from channel 1. Spike in channel 9 has more of a latency after that. So the leading spike, the spike in this case in channel 1, percent concordance with the seizure onset zone. So this suggests that interictal discharges can propagate, which totally makes sense, you know, through white matter tracts or otherwise. This study, similar to the last one, also found that spike abundance only had about 53% correlation to the seizure onset zone. And they also looked at spike amplitude, and they found that it had 75% concordance with the seizure onset zone. And this makes sense, right? Because you think that when you have the highest amplitude that you're probably sitting high or directly over the generator. But in a minority of patients, high amplitude spikes were seen in distant regions, again, suggesting propagation via cortical. So we see this a lot. He has lateral spikes in the right and left hippocampus, but all of their seizures are coming only from or vice versa. In this study, they found that multilobar or bihemispheric interictal did not necessarily have worse postoperative outcomes. All right, seizure on in intracranial EEG, stereo EEG in particular. So I want to try and answer these 4 questions. So first of all, what are the classic, really nice EEG patterns that you can see at seizure onset when you're in the seizure onset zone? Can you tell by looking at this pattern if it's true onset or if it's propagation? Are some seizure onset patterns specific to a pathology? And are some seizure onset patterns indicative of the likelihood of surgical success? I'm not sure I can answer all those questions, but they're all things that I hope get answered in our lifetimes. So approach to analyzing this. So you want, similar to analyzing the interictals, you want to note the morphology and distribution, the anatomical structures involved in the onset and the spread, and the morphology of the spread pattern. You want to note the temporal and spatial relationship to the first clinical sign, logical sequence. So this comes back to that anatomical, electrical, clinical correlation that was discussed earlier. So Patrick Chauvel, who was trained by Bancode and Tolerac, and I was fortunate to be trained by a little bit in fellowship, described semiology as a sentence. So as the different signs occur, they form a sentence which reflects a seizure through different networks and structural and functional anatomic regions in the brain. So just to add on another thing, when you want to note whether the onset precedes the EEG onset, when that happens, you know that you're definitely outside the seizure onset zone and that you're in trouble. Finally, and we'll get to this at the end, but you want to look at whether the seizure onset pattern and the semiology can be replicated via cortical stimulation. So about seizure onset patterns. So high frequency activities in high beta and gamma are the most specific activities recorded at seizure onset. Biologically distinct lesions ranging from focal dysplasias to post-stroke epilepsies to tumoral epilepsies, they can often exhibit the same seizure onset pattern. Seizures associated with lower frequency activity, but some high frequency seizure onset patterns can also occur in spread zones. So you have to be cautious when you're using the morphology of the initial discharge to define the boundaries of the epileptogenic zone, of the region that you think is the epileptogenic zone that you want to remove. So coming back to our patient TB, whose interictal discharges we looked at a few slides ago, I wanted to show you her electroclinical seizures. So she had 115 seizures while the EEG onset was at least 20 seconds or 15 to 20 seconds before the behavioral onset. EEG onset was in the same region as her interictals. So essentially in the right lateral frontal contacts, traveling all the way to the premotor cortex dorsally to the sort of frontal operculum, caudally to rostrally. So initially, the seizure is completely silent as it remains in the lateral frontal lobe. She has no clinical signs. She's sleeping. Then it occurs here. And the end of the slide is cut off. But what happens is that the seizure spreads to the anterior or to the posterior anterior or to the mid cingulate. And when it spreads here, this is when her semiology occurs. So where she's readjusting and shifting her legs in bed, kind of having some axial readjustments. So this is where your anatomical electrical clinical correlation comes in, because we know that a semiology of axial repositioning and axial readjustment is associated with seizure spread to mesial frontal lobe. So what this told us is that her seizure onset zone was pretty, and her interictals also did not involve mesial frontal lobe at all. So her symptomatogenic zone for her seizures was very clearly mesial frontal, and her irritative zone were all pretty clearly dorsolateral frontal lobe. She underwent cortical stimulation and mapping to reproduce any seizures, but we did find that none of the frontal electrodes were in motor cortex. And she ended up undergoing a right lateral frontal lobectomy where we were able to spare the supplementary motor area and her cingulate. And she had no neurologic deficits following the procedure. It was just a month ago, so we're waiting to see how she does. So far, seizure-free. Okay, so what do seizure onset patterns look like in the most beautiful classical cases where you're pretty clearly in the seizure onset zone? So this paper by Peruca et al. From Brain in 2014 analyzed seizure onset patterns in 30 with various lesions from ranging from mesial temporal sclerosis to dysplasias to heterotopias, etc. And they only included patients in whom the clinical onset was after the EEG onset. So the most common pattern that they found was low voltage fast activity, which is clearly visible rhythmic activity greater than 13 hertz, usually 5 to 10 microvolts in initial amplitude. So this was seen in 43% of the cases. Usually low voltage fast was associated with a broader seizure onset zone, and it could be seen in regions of seizure spread as well. It was present across the pathologies. So just showing an example of low voltage fast in seizure onset and spread zones. They gave this example. It was a patient with a left frontal lesion who had seizure onset with low voltage fast activity in the left superior anterior cingulate, and then seizure spread after a few seconds to the right superior anterior cingulate. So the EEG pattern looks pretty much exactly, but there was a time lag, so they elected to only resect the left anterior cingulate. And I don't believe that the patient was entirely seizure-free after this procedure. Okay, so second most common pattern was low frequency, high amplitude periodic spikes. This pattern was, in this paper anyway, was specific to mesial temporal sclerosis. This is an extremely common pattern in mesiotemporal lobe epilepsy, and it could be seen in both onset and spread zones. So this is defined as high voltage spiking at 0.5 to 2 hertz. Okay, so then some other less frequently seen patterns were sharp activity at less than 13 hertz, spike and wave activity, which was just spikes at a higher frequency than the mesial temporal lobe epilepsy pattern. Bursts of high amplitude polyspikes. So this pattern was seen specifically and exclusively in focal cortical dysplasia as well as cortical atrophy. And it only occurred as an onset pattern. And as I'll show you in a couple slides, this was replicated in a future study. Okay. So in this same study, in the patients who had surgery, there was no significant between group difference when comparing EEG onset patterns in patients who did or did not become seizure free. Okay, another paper, just a meta-analysis of all the literature on intracranial EEG, noted that there was just a lot of inconsistency and methodological inconsistency between studies, but a useful finding from this paper was that electrodeclarant noted in 5 studies, mostly in frontal lobe epilepsy, is typically associated with regional or widespread onsets. It's described more frequently when you're doing subdural grids as opposed to stereo EEG. And when you see it, you should really suspect a spread pattern, not an onset pattern. Okay, so another paper that came out in 2019 looked at 252 patients who had stereo EEG and analyzed 820 separate seizures. They had they used the same definitions of patterns as I described in the previous slide. So in this study, they looked at the overall prevalence of each seizure onset pattern. So 79% of the patients had low voltage fast activity. So in this pie chart, low voltage fast activity comprises the blue, the green, the purple, and the red. 79% of patients did have low voltage fast, perhaps preceded by a slow wave or preictal spiking or a burst of polyspikes. Then they classified the seizure onset pattern by the underlying pathology, and they found that the only pathology that had the only seizure onset pattern that was specific to one pathology was that burst of polyspikes prior to low voltage fast activity. So that's the same as the last study that I showed you. So that at least so far seems like it's the only seizure onset pattern specific to a pathology. Finally, so seizure outcomes based on the seizure, surgical outcomes based on the seizure onset pattern. Now, I've found this very useful. So going from the left hand to the right hand side of the screen, so the first 4 bars on the graph are contained low voltage fast activity. So the best outcome was seen in patients who had the burst of polyspikes prior to low voltage fast. So that's your focal cortical dysplasia patients. Then next, where you're just exclusive voltage fast patients, and then the ones with pre-ictal spiking prior to low voltage fast, they had about 60% seizure freedom. Slow wave prior to low voltage fast, that was more like a 50% seizure freedom. And then going from there, theta, alpha, sharp waves, rhythmic slow spikes, or other things like delta brush or beta sharp waves, at all. The study also found that there's better prognosis in focal epilepsies as opposed to network epilepsies. Okay. So often when you do stereo EEG, you can see multiple seizure onset patterns with the same seizure onset zone. Sometimes you see high frequency gamma activity or low voltage fast, and then at other times you see rhythmic high amplitude, low frequency spiking. So what does that mean? The significance at this point is basically unknown. The two studies that I could find were both grid studies, and one found multiple seizure onset patterns in 51% of recorded seizures and 82% of patients with this pattern. Another had a fairly similar percentage of patients with multiple seizure onset patterns, but only 58% of the patients achieved a good outcome. Okay, this paper looked at the association of seizure spread with surgical failure in epilepsy. So they looked at patients who had SEEG explorations in temporal lobe epilepsy. And they grouped the patients into two groups. Were patients with slow spread, where the seizures took more than 10 seconds to spread outside the anterior-medial temporal lobe. And group 2 had rapid spread, where the seizures spread outside the temporal lobe within less than 10 seconds. And it was extremely clear that the patients with slow spread had much better outcomes than the patients with rapid spread. So almost 90% seizure freedom, slow spread pattern, whereas there was only a 20% seizure freedom in the rapid spread patients. So this rapid spread likely plays a significant role in the surgical failure of drug-resistant temporal lobe epilepsy. Okay, so just very quickly, so in stereo EEG, cortical stimulation is another to help determine whether you are in the seizure onset zone. It was developed, this was used originally again by Bancode and Talarak in the 1960s, and its utility has been confirmed in a large study in JAMA Neurology that came out in 2018. I want to, well, just quickly reviewing the study. So they looked at 103 patients with focal drug-resistant epilepsy. They did cortical stimulation with the goal of inducing a habitual electroclinical seizure. This in 57.3% of the patients. In the patients who had these habitual seizures induced by stimulation, and when these same contacts were resected, surgical outcome was typically better. So this supports what Bancode and Talarak found back in the 1960s, which is that when you are able to induce a habitual electrical clinical seizure through cortical stimulation, that can help increase your confidence that your electrodes are in the seizure onset zone. Picture A on the left just shows a patient with a good surgical outcome, and a spontaneous seizure is depicted in the top, and then a stimulation-induced seizure is depicted in the bottom left portion. So while they have the seizures have different morphologies, they generally have the same distribution in the brain. Picture on the right is a patient who had a poor surgical outcome. So their spontaneous seizure is depicted at the top of the screen, and then a stimulation-induced seizure is depicted at the bottom of the screen. So you can see that the distribution of the seizure onset pattern is completely different. So the morphology is different, but more importantly, the distribution is different. And the semiology of the seizure was also different. So in conclusion, the main determinant of surgical outcomes is not just the etiology and the seizure onset pattern, but also the spatial organization of the epileptogenic zone versus network epilepsy. The seizure onset zone must typically be resected, but it alone does not typically define the epileptogenic zone. You should be cautious when using the morphology of the seizure onset pattern to define the resection borders. And interpretation of stereo EEG data should be done in the context of all other available data with an emphasis on anatomical, electrical, clinical correlation. And just for those of you who are interested in further reading on this, there's finally actually a textbook on intracranial EEG. It just came out in 2019, Invasive Studies of the Human Epileptic Brain, and it's quite useful as a resource, first of its kind. So thank you very much. I'm just gonna minimize, let's see.
Dr. That really wonderful talk. Looking in the chat box, it does look like we have, we maybe have a few questions. So the first question for you, is it more likely that seizure onset patterns that don't past activity represent a spread pattern, or that the epilepsy resection to a resective surgery due to it being a wider network?
So, well, some of the other patterns discussed in the talk, like low frequency, high amplitude spiking, that can confer a good prognosis. When in the studies that I looked at saw alpha or delta rhythms or electrodecrement, these tended to confer a poorer prognosis. So it may mean that you're in a region of spread. It may indicate that this is more of a complex network epilepsy. But yes, the fast activity or the low frequency, high amplitude spiking does tend to confer a better prognosis.
We have another question about resources for functional neuroanatomy, and I think this is actually this is a really good question, because it seems that in most of our training, our anatomy is focused more on vascular territories and is kind of more stroke based, and then when we get into the more the gyral anatomy, the sulcal anatomy, and that's a little bit difficult without a lot of resources for that. And so the specific question is about 3D resources for 3D functional neuroanatomy. But to tag on to that, I'm also going to ask if what sorts of resources you have for white matter pathways.
Those are really good questions. So first of all, there's not one good textbook that I've ever found. There are some good papers, and I can try and put together a list, like a Word document, and maybe I can talk to you or Monica about uploading it to the women's neurology group. I think there's like a share drive, because there are at least a few good papers that are good places for getting started. There's a good paper on the functional anatomy of the temporal lobe that I'm thinking of. There's really not a good textbook. White matter tracks. So there is one paper in particular that I've read multiple times. It's by Pandya. I'll include it in the Word document. So white matter tracks, my understanding of them is that a lot of comes from macaque research. A lot of the findings in macaques have been replicated in humans, but I've had to learn to be cautious about translating all of the reading about white matter tracks to humans. But yes, so there is one really good paper. I can't remember the exact name of it, but I will put it in my Word document.
Sounds great. We have another question about the value of DC shift or ultra slow onsets and their relationship to the proximity to the true seizure onset zone. Can you comment on that?
So my understanding of the DC shift, I don't want to misspeak here. So in one of the papers that I showed you guys, they talked about a slow wave prior to low voltage fast activity. And at some point in the paper, they defined the slow wave as DC shift. And this did confer a poorer prognosis, but meaning about 50% seizure freedom. But I'm not sure that I can comment further than that. I'm not used it. So in my fellowship, we really didn't use the DC shift to analyze seizure onset patterns. Sometimes we used high frequency oscillations, but not the DC shift. So.
What program are you using for reconstructions?
It's called Cranial Cloud. It was developed at Vanderbilt. So it's one of the only commercially available reconstruction programs. It's pretty good. So it's kind of a startup company, and they'll work with you to do the reconstructions the day after the procedure. So at Cleveland Clinic, they used Curry, and they had to have their own PhD basically to do the reconstructions and make everything work. So I like Cranial Cloud because it's commercially available.
I'm just going to go back to resources. So you talked a little bit about resources for white matter, white matter connectivity. What about semiology?
Oh, that's another good one. So there is the Luter's surgical textbook. So Luter's textbook of epilepsy surgery has some really good chapters on semiology. Also, Wiley's treatment of epilepsy textbook has a pretty good chapter on seizure semiology. So those are good places to start.
Yeah, I think that Luter's textbook is, even though it's a little bit older now, it's still a really good textbook for semiology. And at least at our institution, we otherwise kind of piece together, multiple papers to try to get the best kind of look at semiology. But that is something that that probably could be updated. Would be really nice for us to have kind of a newer resource that combines the semiology, anatomy, and white matter pathways. That would be excellent.
I picture this book like epilepsy surgery through clinical cases, where you can sort of do semiology and functional neuroanatomy and seizures. That book needs to exist. But another so papers by oh gosh, I'm going to forget his name. Guy from Cleveland Clinic. I just can't remember. It'll come to me. Anyway.
So there is a question on whether, do you evoke seizures by stimulation in a similar percentage of patients that you had mentioned?
I'm not sure I understand the question.
Yeah,
I think they mean compared to the JAMA neurology paper.
Yes, what you had referred to in the talk.
It did seem like a really high percentage of patients that they were able to get a stim-induced seizure in. What was interesting about that paper were the stimulation parameters that they used. So they were stimulating for, I want to say, like up to 30 seconds. So they were doing these like really aggressive cortical stimulations where they were doing, I believe, it was 1 hertz stimulation for up to 30 seconds. So I'm not the findings are compared to the way we do stim at my institution and they did at Cleveland Clinic, which is 50 hertz cortical stim. But yeah, that is a really high percentage, I would say. What do you think, Katie?
So I would say we have been stimulating many more patients now than we previously had. So we used to actually only do stimulation if it was indicated for eloquent cortex, and now we're actually actively trying to stimulate for the purposes of actually eliciting seizures. And so I would say that we're actually, much more successful at this now, but it's because we're more aggressive about it now. That's the purpose of why we're doing the stimulation. And so I would say on actually at least half of patients were able to actually get seizures, but this is because we're turning, we're trying to, so we're pushing the current up quite a lot. Before we were actively trying to do that, it was a much lower proportion of patients.
How high do you go with the current?
So with our depth electrodes, I mean, we usually aren't going. It kind of depends on the location for one. So in the hippocampus, we don't usually go higher than 2 milliamps. But in other areas, we may go as high as 5 or so.
Okay, yeah, that's about how high we go as well. Yeah.
But we will do this if we're actually trying to elicit seizures. We'll do that. Usually we'll start with 1 hertz, but then we do go to 50 hertz if we're not getting anything at 1 hertz. So,
in all regions, not just. Go ahead.
Yeah. So by the time we're doing 1 hertz and then 50 hertz stimulation, and we continually increase the current, often, especially in irritable areas, we are able to get something.
Yeah. So you do that in all regions, the 1 hertz, not just motor cortex. You start at 1 hertz.
That's correct.
Yeah.
So I wouldn't say always. It's, you know, everything with this is very patient specific, of course, but a lot of times, yeah, we'll start at 1 hertz just to get some idea of how irritable the cortex is. So if we can elicit a seizure at 1 hertz, then we really don't need to push it to 50 hertz. We know we'll get something at 50 hertz,
Yeah.
and we don't really need. We're not trying to elicit convulsive seizures by stimulation. We're trying to elicit, you know, kind of small focal and typical seizures.
Right.
So I think that, so I think those are all of the questions from the chat box. Though everyone is very excited for the book that they're anticipating you will write.
I like talking, not reading, but
the semiology and the semiology and anatomy. I do have a question for you myself as well, though. So in cases where you're seeing these kind of rhythmic slow waves or like, you know, alpha, theta, or beta activity, what do you do with that data? So if, do you go ahead and do resections based on that? Do you send the patients back to the OR for additional electrodes? How do you, when you have a pattern that you know is associated with a worse outcome, like what do you do when you see it?
Yeah, well, so just thinking back, I can think of one patient during my fellowship who did undergo a resection despite having that pattern. She had a pattern of theta delta at seizure onset. I believe that she had ring chromosome 20, and that she had a genetic epilepsy, not a not a lesional epilepsy. She ended up undergoing epilepsy surgery. She did get better. Her seizures were all dialeptic, non-convulsive seizures. That's the only time I've ever seen that type of patient operated on. The question of whether to go back to the OR is always a tough one. I feel like it gets debated with every case. Do we put in more electrodes? I'm always against it because I was taught that if it comes to that, if you need to go back and reimplant a second time, you're on a fishing expedition at that point, and it's probably not going to be high yields. But I know it gets discussed a lot. But I've never actually done it.
Yeah. So our experience is that there's kind of one subset of patients where we actually do move forward, and that those are our encephalocele patients. We've actually had, for the past several years, we've had an increasing number of patients that have had encephaloceles that we have thought to be the seizure focus. And in those cases, it's a little bit difficult to get the electrodes exactly into the encephalocele. It's a hard trajectory to get. They're very deep, and so, we assume in those cases that the electrode is somewhere near, but not exactly on or in the encephalocele. And I would say that those are the one cases that we don't actually necessarily have that much of a discussion on, and we're more apt to just go ahead and assume that yes, it's in the encephalocele, and we're just not quite on the lesion.
That makes a lot of sense.
It's difficult to know what to do in those cases.
Yeah, that makes sense because it's about more than just the pattern, I guess. It's about the lesion, the semiology, the concordance of other data. So it makes sense why you would go ahead and do that in that case.
So I have one more question, and I think unless anything else pops up, we'll end with this one, which is, so I personally am interested in neuromodulation, and the JAMA neurology paper that you showed with poor outcomes when there's rapid spread. Do you think that on the basis of that, when we're seeing rapid spread, that we should be moving towards neuromodulation more quickly, or do you think that we should be still attempting resections or ablations in these cases and then using neuromodulation as a backup?
It's a really good question. I don't know the answer to that. I suppose it would depend on if you're talking about the dominant or non-dominant temporal lobe, how rapidly the spread is occurring. It's possible that you could palliate by you could have early or late surgical failure after you do it. So I don't know. I think that now you have lots of options, especially if you're in the dominant temporal lobe. If you're seeing that rapid spread, you probably don't want to do the resection, knowing that you'll, at least in that study, there was only a 20% rate of seizure freedom afterward. What are your thoughts?
Um, yeah, so as the person that does a lot of the programming for these patients, I always think that if there's a shot at doing anything that's going to make them seizure free before neuromodulation, we really should be trying for that.
Yeah.
So,
Mm-hmm.
and that's because when seeing these patients in clinic, it's a very rare patient that feels truly satisfied with seizure reduction.
Mm-hmm. Right.
So, jumping to neuromodulation, really in most cases, 80 to 90% of cases, you may have seizure reduction, but you're not likely to have seizure freedom. And so I think if there's any shot, then we should go for it. But that does have to be balanced with the risk. And when we're resecting or ablating or doing anything destructive, we do have to consider what those risks are. And so if this is an area that is high risk, and we're looking at 20% seizure freedom, then maybe we should be jumping to neuromodulation.
Yeah, it's true though. You got to balance the neuro deficits with the seizure freedom.
Okay, well, I thank you so much for your
Thanks,
wonderful
everyone.
talk, and for everyone who was able to join us today. Hopefully this was really helpful to everyone, and we'll look forward to seeing you in another few months. Right, thanks, everybody.
Bye, everyone.